Bienvenidos para la última parte de este simposio, que es una mesa redonda con expertos. Por una cuestión de gentileza, pues hemos pensado, y no sin menosprecio de los expertos nacionales, que puesto que nos visitan Marti, Roger, Euson, que pues en ese caso sean los expertos, y que de una manera amable, pues lo que se trata es de una charla de salón. Por eso hemos cambiado el look, como la sala de casa, pues en la que de una manera abierta, libre, correcta, pues se puedan preguntar aspectos que nos puedan interesar. Se recuerdan, el secretario general pidió preguntas. Hay una caja llena, pues hay tantas que prácticamente las voy a vaciar, con lo cual quiere decir, efectivamente, yo he dicho eso, pues ostras, qué poco interés hay, pero bueno, no pasa nada, voy a ser yo el que pregunte, y de esa manera los animamos. Lo primero, gracias por esta última tarde con nosotros, pues la parte científica, Marti, Roger, Euson. Y la primera pregunta es una foto, puesto que cada uno viene de un país distinto, viene de una cultura distinta, viene de un modelo distinto. Pues una foto rápida en 2 minutos de cuál es en este momento la situación de la fisioterapia por tu país, cuáles son los campos en los cuales se está produciendo un desarrollo más veloz, cuáles son los problemas con los que en ese momento os encontráis, y cuál es el futuro. Marti.
Okay. Well, for starters, I wouldn't claim to speak for all Australians. And I also work within the musculoskeletal area, so I don't feel I can speak to the situation of physiotherapy in neurology or cardiorespiratory or pediatrics. But in musculoskeletal physiotherapy, I would say things are great. I think physiotherapists are always busy. They make a very good living. They have a good income. We have great autonomy, so we can practice independently, but we also work closely with our medical colleagues, so we're not separate. Research just keeps growing, so we're just have constant new information to integrate into. Sure. So we have constant new information to be integrating. So in many ways, it's just a really exciting time to be a musculoskeletal physiotherapist in Australia. Sure, there's problems. I think there's always challenges in any profession. Some of the challenges, I think, are we have other professions that are competing with us more now. In Australia, we have exercise physiologists who now have a clinical rehabilitation role. So they're actually seeing patients that we would normally see. And that's a challenge for us. And one of the challenges is, do we broaden our education further? So I would say physiotherapy has never been really strong in exercise physiology. I think it's an area we should improve, but then you have to work out your curriculum's only so big, so how far can you extend your curriculum? And we have to make decisions as a profession. Do we go too thin and cover too much to be everything, or do we stay with our strengths? I don't have the answers, but there's some of the challenges that I think our profession faces. But generally, I think it's a really positive time. People are getting older. They need us. People who love sport, they need us. So it's just a good time to work.
Buena foto, ¿no? Para referencia. Euson?
In Canada, it's a very similar situation. I could probably say exactly the same thing as what Mark did. But I'll elaborate on one thing I think that's emerging in Canada is we're following the lead of our UK colleagues and developing new and emerging roles where we're already working alongside our medical colleagues very closely, but we're extending the scope of our physiotherapy practice in ways that hadn't been explored before. So in clinics where we are doing a lot more triage. So that's been a very exciting time for us. And that's across the fields of physiotherapy. So not just musculoskeletal, neurology, in some cardiorespiratory positions as well, where the scope is changing a lot. And with that is more opportunities to get training in those areas. So that's in development. And again, following a lot of our UK colleagues and what they're doing as best practice in extended scope roles. I would say one of the major challenges for us, and I think that's probably the case in any country, is being fiscally responsible. And with that is we're finding it, I think, as a profession, we're having to prove our worth and be able to demonstrate that our outcomes with our patients are strong, they're effective, they're sustained. And so along with that, I think it pushes us to think differently about what we want to research in, and for us at the academic institutions, what we want to put our emphasis in terms of training our students. So as I told you yesterday, we're going through a major redesign in our particular program, and I think that's not unique in just the University of Toronto program. I think across Canada in our various programs, we're all looking at how we can redesign our programs to reflect what's going on in our healthcare system, one of which is to be more innovative in the ways we deliver healthcare. And so with that, I think we have to educate our students very differently. So that would be kind of what's happening in Canada.
No, really good vision. Thank you very much. Roger?
Very similar common themes. The Australians are always so happy and positive. And you are.
That is in the downstairs.
There are, yeah, and Canadians are. You're running around in your snow, you're running around in your sun. In England, it's always raining. So the good things about the UK situation with physiotherapy are what have been mentioned. I think it's really great to see we grow more and more extended scope posts and consultant posts within the National Health System. And so physiotherapists are more responsible. You know, we can do injection therapy, non-medical prescribing, even small surgery in the peripheral limbs. And all that's really good. And we are first contact practitioners. So we're saving the NHS a lot of money, so people can have direct access to physiotherapy in the NHS. They don't need to see a doctor before they come and see him. We take a diagnostic triage role, and all that is great, and that's developing. I think the challenges are two things, really. One, cost effectiveness. We have also got to prove ourselves in terms of cost effectiveness, and the model we work with in the moment, we can't do that. At our national conference just 2 or 3 weeks ago, the final lecture was by a guy called Sir Muir Gray, who was, again, one of the original developers and proponents of the evidence-based medicine movement, a medic and a knight. And he laid down a challenge to physiotherapy, so we've got to reduce our costs and increase our clinical effectiveness. And the only way we can do that is to think about something that he termed population physiotherapy. We've got to appeal to society at a population level rather than an individual level. And whilst I personally agree with that, I think as my talk was based around yesterday, the individual is still the centre of it, but it's how we relate those two things. So that's a problem. And also I think there's a challenge with a shift in response to emerging evidence. And like Euson and Mark said, curriculum change is high on the agenda, and we're looking at ways which we can replace old modalities with new modalities, how pain science affects how we deliver our education, how we introduce more therapeutic exercise into the curriculum, and how we compete with other exercise groups like strength and conditioning and sports rehabilitation. That's not just in sport, that's in all populations, elderly, neurology, cardiorespiratory, deconditioned patients. And we started a thing 2 years ago called hashtag Movement for Movement, and there's an organisation called Exercise Works, which we're trying to infiltrate exercise education across the board into medical education, nursing, occupational therapy, physiotherapy. So I don't think it needs to be a competition, but there needs to be a strategy to how we do that. So that's our challenge at the moment.
Bien, gracias. Parece que un hecho común es la autonomía, la profesión, que es algo necesario y que es algo pues a veces complicado. ¿Cuáles, en vuestra opinión, los pasos de una manera muy concreta para poder alcanzar la autonomía de la profesión? La plena independencia, no únicamente pues en la práctica, sino pues en el ejercicio de la profesión.
I think this is something that the three of us over the last few days have been discussing a lot more I think it comes from the way we conceptualize and think. And there's lots of value in thinking in multiple ways, and I think the autonomy, I think, will come from having a united front, but also different ways of thinking about the same problem. I think if we, I see it in Canada anyway, that if we only think in one way, I think part of the autonomy comes from how other people see us. And if we limit the way we view things, so for example, exercise, if we think it's a threat, if other people infringe on what physiotherapists do to prescribe exercises, then it's hard to actually exercise that autonomy. I think the way other people see us have a huge bearing on that. So that's one way that I think Canada's doing well in that area, is because I think we try our best to work with other professionals so that we can exercise their autonomy, because other people are respecting us for what we do.
Yeah, those are good comments about autonomy, and I suppose I would say autonomy has to be earned. It's not a given right, and I think our profession has earned it over many years in terms of the growth. We're not the same as we were many years ago, the research that builds our knowledge. So I think autonomy has to really be grounded in a good growing knowledge base, a good research platform. Obviously, we all think reasoning is really important, so it's being able to apply all that knowledge that we get from research to practice, and that requires really good reasoning to do that. I think we also need to, there's a small area that I see sometimes there's a gap. We call it medical screening. It's screening for non-musculoskeletal problems. Again, this is in my area of practice. And sometimes I wonder how Australia got independent practice 40 years ago, I think they got it, when I know they weren't taught that. So a patient would come to see a physiotherapist, and they still just looked at him only as a musculoskeletal case. They didn't consider other possibilities. And now we're more formally bringing that into our education. And I'd really emphasize that's not to diagnose for example, visceral disease. That's not who we are, but it's to screen, to know when to refer back to other health practitioners for further investigation. And I think that's an important part of it. And that makes me think of another point that, yes, autonomy, but not really total independence, because I think healthcare is always better as a team. If I see a patient who wasn't referred to me, I almost always ask their permission to write to their GP, because I think their healthcare is better if their GP is aware that they've had this little problem, it's been managed this way, so there's this greater knowledge about the patient. So I think we continue to work with our medical colleagues in that sense.
Eso hay que decir que es un camino, en algunas partes, pues este camino tiene alguna similitud con lo que se quiere realizar aquí, en nuestro país, pero es un camino muy duro para recorrer. Roger, your position about the autonomy?
Yeah, the same point. Again, I think it's about autonomy rather than independence, and again, support the fact that it's got to be earned. We need the evidence to show we're two things, cost-effective and clinically effective, and the more evidence of that we can get, the better. I think we are in a great position. You know, if you look at the last global burden of disease study 2 or 3 years ago now, you know, chronic musculoskeletal disease is right at the top of the table, above cancer, above cardiovascular disease, above systemic disease. And if we can prove that we can impact on that global burden, we put ourselves in a really strong position, nationally and internationally, because this is global. And I think, again, it's not about independence, because I think we should think of physiotherapy globally, rather than, it's important to look at each country, but we need to work globally and have global strategies to impact on that increase in burden of disease from chronic musculoskeletal conditions. And it's terrible that it's right at the top, but it does put us in a good position, because if we can provide evidence that physiotherapy can impact on the world's biggest killer, you know, governments, well, they are starting to take notice, but they will take more notice, and you know, we can do that, and it's about raising professional identity and position ourselves better. And in the private market, I think things like, I've always thought this for a long time, I think we undervalue ourselves. I can only talk about the UK private market. If you look at the fees we charge for patients, we should be comparing ourselves to lawyers and architects and other people of a similar professional status. And you know, in the UK we might charge £50 for a 40-minute session or something. A lawyer would charge £300. Why aren't we charging that? And why isn't society viewing us at the same professional standing as somebody like a lawyer or an architect or whatever? Or a doctor, you know, working in private practice.
Gracias, porque es una parte para nosotros, ahora mismo por nuestro país, la cuestión de la autonomía es un objetivo. Hay una disociación entre la práctica privada y la práctica en centros públicos, con una mayor cuota de autonomía por el sector privado y menor por el sector público. Por último, para ya acabar este primer bloque que ahora vamos a tocar, la cuestión de qué relación hay entre la mejor autonomía por la profesión y la mayor expertía de los terapeutas en el manejo de herramientas como pueden ser la valoración, el diagnóstico.
Sorry, can you repeat that question?
Yes. ¿Qué relación podemos crear entre el desarrollo de la autonomía profesional y la mejora de habilidades como pueden ser el diagnóstico, por la valoración, por medio pues las herramientas que precisemos.
I'll have a go.
Yeah, sure.
If I get the question right, I think, along with improving our knowledge continually, and that wouldn't just be about disease and pathology and pain mechanisms, it has to be about assessment. It has to be an assessment of physical health, assessment of mental health, psychosocial factors. I think we need to be rigorous in all aspects of it. We need to be critical of our assessments in terms of objectivity where we can be objective and validity. That doesn't mean, in my opinion, that we throw out every assessment procedure that doesn't have proven validity. And that's another discussion we can go into if you want to, but I think you have to be critical of those procedures that don't have good validity, but they can still have a place in your overall assessment. But I guess the thing I want to link it to autonomy, something I could have said about describing the situation in Australia is we have really good respect from our medical colleagues, in my opinion. Of course, there's always some doctors who aren't that way, but mostly they really respect us, and they see us as experts in this area of practice, and they use us as experts in this area of practice. And as long as we are, as Roger says, cost effective, we're not over-servicing, and we're accountable for what we do to the best we can, that'll continue. And I think that's part of establishing autonomy. You know, they want us to diagnose their patients and manage their patients because they can't do what we can do in this area. And that's how it should be, because we specialize in this area. So there's a real hand-in-hand relationship, I think, between knowledge and skills and autonomy in that sense.
Thank you. Simposio?
So when I think about autonomous practice, I think about some of the colleagues I have who are highly autonomous in their practice and who are also experts in their field. And I think about what kind of skills they have that I would want my students to develop into, to also gain. And I think one of the things, and I think I spoke about this, was their flexibility in their thinking. A lot of it comes down to the clinical skills are there. I think they have developed their technical skills, their handling skills, but I think their excellence shows when they can make a decision, even though they don't have all the information or the information is ambiguous, and they can be flexible. And I think that's, to Mark's point, I think that's one of the reasons why they are seen as experts by other medical professionals, by their patients. That's where they get sought out, because they can make those decisions and be flexible and deal with ambiguity. And I think as the health of our populations getting more complex, and we have many more people with comorbidities, I think that's really important for our students our learners and our physios to develop into, to have that kind of flexibility in their thinking.
Yes, same again. If we can, and then the final layer is to sort of formally document that and disseminate that information that we are good at these skills, and and that can be we could use technology. So we saw some great use of ultrasound today, and we can again demonstrate that as long as we can map what that means onto a bigger framework of meaningful impact on meaningful health burden. And you should look at some work that's recently been published by a guy in the UK called Rob Goodwin, who's been producing his data on looking at the how good physios are as first contact practitioners in that assessment role, in that diagnosis role. So one of the studies that was published a couple of years ago, and there's been more data since, showed that in one large region of the UK where this was trialled, so they put physios versus general practitioners, medics, and over a period of 6 months, half of the population went to see the physio, and half went to see the GP with a range of conditions, with minimal triage. And the outcomes were very positive. And in fact, the big worry was things like, well, physios wouldn't be as good as assessing a broad range of conditions, and they might miss serious pathology and things like that. But in fact, the physios missed less serious pathology over that 6 months than the GPs did. So the physios were showing better reasoning and assessment skills as first contact practitioners than GPs. Since then, that region has changed its structure and has placed physiotherapists as first contact practitioners in a whole range of GP practices throughout that region. And that is being audited and monitored, and they're improving their clinical outcomes, and they're reducing their costs of the service. And that's been done in a very short space of time. So if we can look at more models like that and really sort of disseminate that and repeat it and show that we are, you've got to have that cost effectiveness on there as well. But I think there's very, very, very good potential.
Jose, can I add a comment? I want to pick up on something that Euson said about flexibility, and I want to try to link it back to a couple presentations that we've had in this conference. There was, and I'm sorry, I can't remember who presented what, but there was a presentation of clinical reasoning competence as a competency, which I agree with. It is. And there's also a construct that is very similar to flexibility in thinking. They talk about adaptive expertise, the ability to adapt in a situation, which is usually a situation of ambiguity when it's a complex presentation and it's not clear. And that links to another concept of competence versus capability. And it's kind of just language, but it's interesting language, because the people who use those two words would define competence as the ability to perform this set criteria, and we tick the boxes that you're competent, where capability is the ability to do that, but also the ability to perform in unfamiliar situations, which is a little bit like this adaptive expertise, the ability to, when you see a patient that's never been quite like any other patient you've seen, or they're not responding. And that flexibility or adaptive or capability in reasoning, I think, is also an important attribute that we can build in our profession.
Bien, vamos, no sé si sobre este tópico de la autonomía hay alguna pregunta para ir ya cerrando partes de esta charla. Pues una primera era pues hablar de este primer visión sobre la autonomía. Me parece que el mensaje es claro, creo que somos buenos, pero bueno, pues hay que demostrarlo. Aquí tenemos una pregunta.
Hola, buenas tardes. A mí me genera curiosidad, y ya aprovechando que vienen de diferentes países, me gustaría mucho saber cuál es la visión que proyectamos los fisioterapeutas de la fisioterapia clínica.
Wait. They can't hear in the...
They can't hear it in the booth.
Me genera curiosidad y quisiera saber, aprovechando que son fisioterapeutas de distintos países, ¿cuál es la visión que proyectamos los fisioterapeutas o la fisioterapia que hacemos desde España? Y quisiera saber ya también, pues, cuál consideran ellos que son nuestros puntos fuertes y qué es lo que deberíamos de mejorar. Gracias.
Gracias por la pregunta, porque es muy necesaria. Muchas gracias.
That's a hard question.
Be polite, ¿eh?
You're the best I've ever seen in the whole world, ever.
Good answer. Yeah. I have to say, though, I've been very inspired by the number of people who are committed to the profession. So the people I've talked to seem very enthusiastic and motivated about bettering the profession. So I think that's a great strength of yours and to be able to have this kind of commitment. It's easy in become complacent. It's easy to fall into a place where you're doing your thing on your own and practice in your own setting. But it's another to gather together like this and to be able to talk about some of these things that are not easy to talk about, like clinical reasoning, professional practice, professional issues. So kudos to you to be able to do that. So I think that's a big strength of yours.
I wouldn't presume to comment or judge Spanish physiotherapy. I haven't even seen, clinicians in practice to know that, and it wouldn't be my place to do that. But I will comment on what I see in the literature, and I have seen that change, as it has everywhere in the world, but I've seen it change enormously. And I guess the way I would describe it is the volume of contributions coming out of Spain in the literature that I'd say 20 years ago, I didn't read much that was coming. That may just be me, but I wasn't seeing much research, publications that were contributing in the same way, where now it's very, very common. There's some fantastic research that's really contributing to the body of our knowledge, and it's at the research level, at the clinical level. I don't know if Raphael's still here, but he's got a case in our new clinical reasoning book, and it's one of the best cases in the book. So to me, that's just a real testament to advancement in contributions in the literature anyway.
And same again, it's not my position to make that sort of judgment. I was chatting down at coffee, somebody asked me this question earlier, and it's difficult. My only exposure to Spanish physiotherapy is this last 2 days. I had no expectations, no ideas of what was going to happen. The only I've taught and worked in Italy and France before, and you're much better than Italians and French physios. What is evident is there's so much commitment and so much passion and so much potential for wherever you want to go. And as Mark says, on the research side, that's clearly developing, and it's more of the same. And we're learning as much from you as you are from us. The level that you've been thinking about things and the presentations we've seen where people have really taken a subject matter, in this case clinical reasoning, and really thought about it and really thought how it impacts on not only them but on the profession. This is exactly what we all should be doing. So it's fantastic.
Porque soy de un país, ¿no? Pues son varios países y yo soy otro. Yo creo que somos buenos y pues hay que creerlo, pues que lo somos. No hay que tener complejos, creo que aún hay algunos complejos. Bien, más preguntas sobre este primer. Por ahí hay otra.
Hola, espera, que tengo el micro en la mano ya que estoy, otra vez. Bueno, hablando un poco de autonomía, a mí me vienen a la cabeza siempre ciertas cuestiones relacionadas con la cronicidad, y me consta que la WCPT también ha pensado en ello. Hay patologías crónicas que se asocian con el dolor de espalda, que es crónico y muy recurrente, como problemas metabólicos, obesidad, diabetes, y son enfermedades que están en crecimiento. Mi pregunta es, ¿qué rol creen, ya que tienen autonomía en sus respectivos países, qué rol creen que juega el fisioterapeuta a nivel nacional en sus países o a nivel mundial en este tipo de patologías crónicas de alta prevalencia? Gracias.
Gracias por la pregunta.
So I'm just going to tag on to something that Roger had said, the idea of population health, our role in addressing population issues, while at the same time attending to some of the individual aspects of care. I think that's the tension that we as physios need to carefully attend to. that we are not putting all our efforts into dealing with population issues, although it's very important, as we can see, but not forgetting that there are individuals within those populations. And the individual variations in how people present is just as important as some of the common features. So I don't have a clear answer for how to do that, but I think efforts at trying to get at both is important. So when we talk about maybe training some of our trainees to think that way, I think it's really important that they know that there's a difference, that the physios have a role in individualized kind of care as well as population type of care, so that they're not dismissing one and only building their skills in the other.
We sort of talked about this ourselves, and I'm going to suggest that yes, we are exercise therapists, we're manual therapists, we're pain therapists. You could probably name a few other things, but I think we all think that we're teachers. Kind of over everything else we do, we're teachers, and we educate patients to reconceptualize the meaning of their problems, to understand pain, to alter lifestyle, to change behaviors, to change movement patterns and control. So I think one of our key roles is as teachers, but it does also touch on how well are we trained to be teachers. And I think it's probably a gap in our education, because a teacher would study, what, 4 years, an education degree? That would include a lot of learning theory to be able to teach and promote change. And I think we'd probably do that quite well from our own experiential learning, but I think we could probably learn to do it even better if we strengthen our education theory underpinning our teaching that we do. We have a new program we're developing for our master's course, and at the moment we're choosing to call it Facilitating Change. And it's a course, a subject, to try to teach our postgraduate students how to facilitate change in their patients, whether it's conceptualization or behavior or lifestyle. And it's not only strategies to facilitate change, and there's many different strategies that you can use, from cognitive behavioral therapy to motivational interviewing. There's a long list, but it's also understanding the theory that underpins them, and that we can use that theory like we do in other aspects of our practice, physiology, to guide exercise prescription, for example, and then just get perhaps more skilled at the teaching that we already do.
Again, agree. We're not going to get anywhere unless we've got that skill to change behaviour, so that's central to it all. But this is such a great question. It's such an important question. So I'll come at it from an exercise fundamentalist point of view. So we have something in the UK called Make Every Contact Count, which is every single health care professional, whether it's a doctor, a nurse, an occupational therapist, a physical therapist, has to understand that every time they interact with an individual patient, they need to try and get as much behavioural change and impact on that person's life as possible in terms of their health status. So, for example, a physiotherapist, in the context of Make Every Contact Count, would see themselves as having some responsibility for their wider health issues, like their weight and their sleep and their diet. So practically, we might look at things like taking blood pressure and vital signs and advice on that. Obviously, there's a skill set there. So at an individual level, I think we do have that. The link between musculoskeletal conditions, chronic musculoskeletal, metabolic disease, cardiovascular disease, can be exercise. So in fact, we can, through exercise, have an impact on metabolic disease and cardiovascular disease in terms of mortality and morbidity. And again, at a population level, we can look at strategies to do that. And I think, as well as good teachers, we perhaps need to see ourselves as good service change implementers and quality improvement leaders And to be a leader, you don't need to be high up there. You can be a leader at the shop floor level and make change. Do you have some? Do you know about park run? Do you have park run in Spain? Is that a familiar thing? I'm guessing no. So there's a thing that started a few years. Do you have park run? No? Okay. Right, I can sell you this. It's like a franchise thing. So in the UK, at 9 o'clock every Saturday morning, all over the UK, in something like 750 odd places, parks around the UK, there's a 5K recreational run. Hundreds of thousands of people every Saturday morning get out of bed and run 5K at 9 o'clock every single Saturday morning. Now, that was invented about 5 years ago by a guy who just started running. He wasn't a healthcare, he was, I don't know, an office worker or something. And he decided he wanted to get himself a bit fitter, and he did this, and then he started this thing. Now, my question is, it's absolutely brilliant. The impact that's having there's tons of data about this now, and the impact it's having on health status across the board, cardiovascular, metabolic, musculoskeletal, is immense. My question is, why didn't a physiotherapist lead on that, or a similar thing? You know, how come an office worker was able to have more population level impact on health status than a physiotherapist? I don't think we see ourselves as change leaders, and we are, you know, by definition we are. We just need to realize that more and look at things like that as well.
Can I just add to that? I like the idea of having physios see themselves as a change leader, a change agent. I think having physios, I would extend that to say it would be great if we all saw ourselves as change leaders for groups of people as well as for individuals, and knowing when to go back and forth between the two, and knowing when you have to switch gears because it's different doing that with individuals versus groups, knowing when to switch gears and say, well, I need to change my way of talking, communicating, doing things because I'm talking to an individual versus a group. I think that's the critical part of that.
Pues hay un hecho que yo creo que es... Ah, perdón, había una pregunta por ahí. Y había otra por ahí. Perdona que te deje, pero había pues otro turno por ahí arriba. Voy contigo, presidente. Había otra por ahí arriba.
Hola, bueno, buenas tardes. En primer lugar, gracias al colegio por lo que creo que es una magnífica iniciativa. El poder tener estos 2 días de una formación sin duda de máxima calidad con los ponentes de nivel que hemos tenido. Y gracias a Marc, a Euson y a Roger por estar aquí con nosotros y poder compartir de primera mano todo lo que hemos leído en sus libros y en sus diversas publicaciones. Voy a hacer una pequeña reflexión de lo que han sido para mí estos 2 días, que lleva implícitas una serie de preguntas que me gustaría que los ponentes pudieran compartir conmigo su opinión. Hemos visto como uno de los pilares del razonamiento clínico es el conocimiento, y cómo este conocimiento dentro de una profesión, como es la fisioterapia, debe estar basada en el conocimiento científico, en los avances científicos de la investigación dentro de la profesión, pero también en el avance científico de las ciencias afines y de las ciencias básicas. Esto creo que es imprescindible, entre otras cosas, para poder tener un lenguaje común dentro de una profesión, ya que creo que todos podéis compartir la visión de que como fisioterapeutas tenemos demasiados lenguajes, demasiadas visiones diferentes, y como lenguaje común para comunicarnos con otros profesionales sanitarios, como son los médicos o los enfermeros. Tengo la impresión, y esto es una reflexión personal que no tiene por qué reflejar la realidad de la fisioterapia en España, y es que dentro de nuestra formación universitaria, dentro de nuestra formación de posgrado, la pseudociencia forma parte intrínseca de la profesión, está totalmente imbricada dentro de los planes de estudio, de los conocimientos, de las opciones formativas de posgrado, de manera que el fisioterapeuta en España tiene demasiados o muchos caminos abiertos una vez que concluye su formación, y muchos de estos caminos son incompatibles con este conocimiento científico y con este razonamiento clínico que hemos estado viendo estos 2 días, totalmente incompatibles. Esto me lleva a plantearme un par de preguntas o 3, que son si la realidad en sus países es la misma, sobre todo a nivel universitario, a nivel de grado, si la pseudociencia está tan presente, tan mezclada y tan imbricada con el conocimiento en el que se sustenta el razonamiento clínico en fisioterapia, si esto ha sido así en el pasado, pero ya no lo es, y qué camino han seguido para convencer al resto de colegas de la profesión en que el camino adecuado es el de la puesta en cuestión y el de la investigación acerca de nuestras intervenciones, y si creen que esto puede estar lastrando el desarrollo de la profesión en España y, por tanto, lastrando las posibilidades de autonomía profesional respecto a otros profesionales sanitarios. Gracias.
Thank you for a great question. I'll start to answer it and see if it's addressing your question. So thank you for your comment about the multiple terms or ways to look at maybe a single concept. And I think the idea of having multiple ways of looking at something is healthy. I think we should encourage that. Where I think it becomes a problem is when we see it as the multiple ways of seeing something as in competition with each other rather than being complementary. So when you're thinking about the scientific research or scientific evidence, I think we need to look at it first with a critical eye, but also see it as much as possible as complementing each other in trying to understand a particular phenomenon or concept. So clinical reasoning, for example, there's no way you can understand it by just studying it with quantitative methods, for example. You need some narratives to try and describe what clinical reasoning is. So if we as a profession are able to see things and look at and test things and discuss things from different angles, I think it enriches our understanding of what it is that we're trying to grapple with. So again, the three of us, we've been talking in the last few days about the different ways in our own country that we are sometimes our worst enemy and trying to pit one view against another. So it's not, I think it's a global problem. I don't think it's just unique to any particular country. But I think that's one of the issues that I see. It stems from the fact that we're limiting ourselves and seeing something from a singular view or just a few views versus being more open-minded and seeing things as complementary. So I think if we can view scientific evidence as one source and one view of looking at something, I think it's a bit more of that's more of a healthy outlook, and I think we can accomplish more. Another thing I just want to say is, I think at the core of it is, I don't think the key issue is whether my view is right or your view is right, but that what is best for the patient. I think the question needs to be asked of what is the ultimate outcome of what we're trying to discuss. For us, I think the ultimate answer is trying to address that question about what is the best for our patient, and then our discussions hopefully should be surrounding that versus my view and your view.
So my point, Roger or Mark?
It's another fantastic question, and you know there is no straight answer, and as Ethan said, you know all those things to be considered. We're currently going through a curriculum change at the moment in our university, and we're thinking about exactly this same idea. Pseudoscience versus science. I think there probably needs to be a level of learning within the curriculum that allows a student to work that out themselves, because information and knowledge will be changing all the time and things will come and go. So if you've got that basic ability to work out as a professional what constitutes the best, the most trustworthy source of knowledge versus something else, that's a start. You know, is something biologically plausible? Can it be tested? Simple questions like that for them to think about. So then you can start to make that differentiation. What choices and what are the drivers for people deciding what goes in a curriculum and comes out of curriculum? We've been talking about this, and that's so complex and multifactorial. Obviously, scientific data needs to sit in there and underpin a lot of things, but there's also a lot of other non-science things, and I don't mean, you know, non-science things being a pseudo-scientific intervention or something like that, but there are other stuff that needs to go in there, and it just amazes me all the time. You know, just like 2 or 3 days ago, there was an article on low back pain in one of our national papers, the Daily Express, written by a physiotherapist of 30 years experience. And she wrote this is how to avoid getting low back pain. And it was true pseudoscience, real old school thinking. And I just think, how can a health professional do that? How can they not differentiate between what is actually pseudoscientific and actually scientific? So it's not about the thing, it's about the person and how they make that. The language thing is also important. We need a common language. You know, every profession and every discipline has its own language. Physics does, chemistry does, psychology does. But the skill is to leave that in its place and have those discussions within our profession. We need to be able to communicate with other professionals in a common language. And so that's. It is a bit of a challenge, but we, you know, in order to develop and explore ideas at a deeper level, we do need a vocabulary to do that. But as long as we realise that is our discipline-specific vocabulary, it doesn't mean anything to anybody else, and we communicate with people in another way. That's fine. Good question.
Good. Mark?
The majority of the discoveries in the history of science haven't come through careful experimentation. That comes from, was it Thomas Kuhn book, The History of Science. And the majority of breakthroughs in the history of science have come through either the lone inspiration of an individual or an accident in an experiment, an unintended finding. And the fact that everybody clapped to your question means that it resonated with people here, and it makes me wonder, what pseudoscience are you talking about? Because I'm not sure what you're referring to. Are people slapping fish together when they're treating patients, or what are they doing that you're calling pseudoscience? But of course, there is a point that is unethical and inappropriate, that is wrong. But I'll put another question out there. This is my chance to get lateral thinking in. Do you think there's a place for creative and lateral thinking as from physiotherapists in our clinical reasoning? Or should we only practice clear, logic, deductive reasoning? Here are the premises. I find these premises hold true in this patient, therefore I can apply this logic to my deduction. It's what we use all the time. It's the basis of, deductive logic is the basis of most of our clinical reasoning. But I'm going to argue that I'd hate to see creative lateral thinking go away. If you think of some of the innovative therapies and variations of therapies that have emerged, that have gone on to be investigated through research, because that's an essential process. But before the research, there's innovative individuals, people who are out there trying something a little different from what they were taught. And I would say there is a place for that, to generate new ideas as long as that individual is a good logical thinker, a good critical thinker. So they're not doing that carelessly, but then you can generate new ideas. If you're interested in the whole area of lateral thinking, you have to read some of the textbooks by Edward de Bono, if you ever heard him, the guy from Malta who must have 50 textbooks on creative and lateral thinking and teaching children thinking, and they're brilliant. Or if you ever get a chance to listen to him, he's brilliant. And it's an aspect of reasoning that hasn't really come out in this conference because I don't think it's not the main part of our reasoning. But if you always look at things the same way, you won't ever see another way of looking at it. Or if you put things into clinical patterns and you've got 3 boxes, every shoulder problem is going to be a tendon problem, a capsule problem, or a bursitis. If you've only got 3 boxes to put every single patient in, you can't see variations of those, you can't see overlapping patterns. So clinical patterns, on one hand, they're organization of knowledge, and they're a really useful processing tool to more efficiently examine and understand a patient's problem. But they're also the biggest source of clinical reasoning errors because people get locked into their clinical patterns. They can't see outside their favorite patterns. A really nice talk about errors and confirmation bias that somebody gave summarizes one of the problems with clinical patterns. So learn clinical patterns, but don't trust the clinical patterns. Be a critical thinker, but also be a creative and a lateral thinker to be willing to generate new ideas. And Roger was the one who taught me the concept of abductive reasoning. I don't think I'd heard that until Roger brought it up, which is tell him about abductive. I'll let you jump in here and tell him what that is.
It's another logical form. We talk about deductive reasoning, which is the if A and B then C, the very strict, very robust thing. And inductive reasoning, I've seen something a lot of times, so therefore the next one. But if you look at Sherlock Holmes or Columbo or whatever, they actually don't use any of those reasoning forms. They use something called abductive reasoning. Another word for that is inference to the best explanation. There's something humanly intuitive about it, and and it allows for some creativity. So Sherlock Holmes would walk into a room and he'd see a curtain with some shoes sticking out the bottom of the curtains and the room's a mess. He's never seen that before, and there's no deductive form that he can work that out. But the inference to the best explanation is the guy that's burgled the room is hiding behind the curtains. There's something creative and human there. And I think that underpins, well, I don't think, a lot of people who've written in this in psychology and philosophy think that type of reasoning that allows for that level of creativity as well as some robust logic is probably what we do the best. But so if we do chop out that creativity, we've probably lost our best approach to clinical practice. So,
and I think you mentioned something really important, that both of you, the creativity that we're talking about isn't just it's nilly-willy, you're just drawing something out of the thin air, but it's informed creativity, so that your experience, you haven't seen this particular scenario before, but you can't dismiss what you've already seen or experienced in your life, right? So it's informed by all of that, and it could include book knowledge, your tacit knowledge, things that you just do intuitively, your intuition. All that informs the creativity. So it's not that it's just crazy and wild and out of nowhere. That creativity is honed, and that's something that we're trying to kind of define. It's really hard to do. Define what are the competencies or what are the criteria to judge a learner by, so that I know they can exercise creativity within this kind of informed framework. So, yeah, that's what I think.
Muchas gracias. Es una pregunta muy interesante y no, perdóname, pues un apunte para darte pie, y creo que nos pone sobre el foco de que se vive en nuestra profesión un momento de cambio, y precisamente algunas pues, las ideas que vosotros habéis dejado hoy y este pasado día pues nos permita perder ese miedo pues, a ese cambio que muchas veces generan sensaciones. Había la pregunta por aquí para mi buen amigo.
This better be good.
Hola. Buenas tardes. Bueno, en primer lugar, he dormido 2 horas. Por culpa de la noche madrileña he dormido 2 horas. Entonces no estoy muy lúcido. Voy a hablar de algo feo. No voy a hablar de algo bonito ni agradable de escuchar, pero bueno, necesito compartirlo con los compañeros. Primero, welcome to Spain, the most beautiful, strange and nasty country all over the world. Somos muy especiales en España, muy especiales. Soy el presidente del Colegio Andaluz y voy a hablar sobre un tema poniendo un ejemplo de lo que pasa en España, en nuestra profesión, en mi opinión. Y voy a poner un ejemplo hablando de la Edad Media. De la Edad Media. En primer lugar, yo creo que en Toronto, en Canadá, no hay nadie mejor que Eduardo Fondevila en Razonamiento Clínico. Creo que en Inglaterra no hay nadie mejor que Rafa Torres, hablando de dolor crónico. Y creo que en Australia no hay nadie mejor que Antonio Cuesta para hablar de ejercicio terapéutico. Lo tengo clarísimo. Pero ustedes han ganado, de momento. Entonces, en la Edad Media, los señores feudales, los reyes, vivían muy bien. Eran muy poquitos, muy pocos. Y los reyes vivían del carajo. No sé cómo traducir esto en inglés, pero bueno, vivían muy bien. Aquí en España, los colegios, los representantes de los colegios, los formadores, algunos influencers de Twitter y de Facebook viven muy bien, pero son muy poquitos. El 90% de los compañeros españoles ganan 1.000 euros al mes. Ese es el gran problema que tenemos en España. En la Edad Media íbamos a la guerra hablando de la verdadera religión y de que mi país necesita hacer esto, entrar en guerra con Inglaterra, conquistar América. Y la gente estaba muerta de hambre en sus casas. La gente pagaba los tributos al rey y estaba muerta de hambre. Pero el rey vivía muy bien y los nobles iban a la guerra a luchar por ciertas cosas. En España pasa eso. Tenemos un gravísimo problema. Tenemos 47 universidades, más que sus 3 países juntos. 47, donde se imparte enseñanza de fisioterapia. Aquí está el señor presidente de los colegios de fisioterapia de España, 55.000 fisioterapeutas. El señor presidente de la Asociación de Fisioterapia de España, que nos representa a nivel mundial. Pero nosotros seguimos hablando de eso, de cuestiones muy importantes, pero aquí nadie habla de que estamos tiesos, de que la gente cierra consultas, de que la gente está sobreviviendo en sus consultas, de que el sistema público de salud nos ha cerrado la puerta. Pero la batalla es qué somos, dónde vamos, hay que formarse más, claro, hay que gastar más dinero, esto le viene muy bien a muchos señores que viven de eso, pero aquí nadie habla del dinero, Si son tan amables, me gustaría una sola pregunta. ¿Cuál es el sueldo medio de los fisioterapeutas en su país? No lo que cobran ustedes, sino ¿cuál es el sueldo medio de un fisioterapeuta en Australia, en Canadá y en el Reino Unido? Muchísimas gracias.
I don't know exactly what it is in Canada. I think the starting wage for a new graduate physiotherapist is anywhere between $60,000 and $80,000 a year, so Canadian dollars, so it's not worth very much. I don't know what, and I don't know what the situation here is exactly. I can't I can't say that I would be able to understand it just within, you know, the couple days that I've been here. But I'll tell you something about what it's like being in my province within Canada. So I've been a physio for almost 22 years, and from the get-go, we've always been trying to lobby for something. For example, lobbying for, we had a very similar situation where physios were paid for patients who were undergoing rehabilitation from a work-related injury. The work-related injury, that board would pay for their physiotherapy visit, and it would be very low. And so physios, to compensate for that, would have to see many, many patients per hour. So very similar to what's going on here, as I understand it. So that was in 1996. Last year, 2016, was when after 20 years of lobbying and multiple goes at it, was when we were able to advocate for ourselves enough that changed a little bit. It's not ideal still, but I think how we've dealt with it has been, and I don't think this is the solution for everyone, how we dealt with it was to really have advocacy campaigns around issues of access. Again, not just about the bottom line, which is how much we're being paid, although that's very important, but advocacy for access for patients, fair access for patients, and to be persistent at it. I don't think, and again, our situation, our healthcare system and our political system is very different than here, but it's through tons of work and persistence that has helped us in that particular issue. I think the other thing that we've tried to do is develop some leaders who can be advocates within our profession. There's a huge campaign over the last, I would say, 5 years in our Canadian Association of Physios to develop leaders. Some of the efforts were diverted to that particular issue of fair wages, some to other advocacy campaigns, but I think that has, in part, helped give us a bit more autonomy and a bit more voice. But it's a big effort, right? And it has to be a coherent effort. I don't think it's, you know, Ontario, that's the province I'm from. If we did it on our own, it wouldn't work. We had to have a strategy across Canada to be able to do that. So it's not easy, and it takes so much time and effort to do that, but I think we have, right, I believe we have a very committed group of people working at that kind of advocacy level. And leadership level that has really moved us forward. But it's taken a long time for that to happen. So I don't have an easy answer for that.
I wouldn't have much to add to that other than saying we have a similar situation with our professional association in Australia, which is optional if you want to be a member, so it's not mandatory. And people choose not to because it costs about, I think, $1,000 a year to be a member of our association. Oh, by the way, I think our salary is also $60,000 to $80,000 for new graduates. But I've always felt really strongly that you support your profession because of these sort of reasons. So our profession is very, very active in lobbying government to better our situation in terms of financial compensation, etc. And they do have some successes, definitely over, you know, probably not where we would like to be, but we're definitely winning on that front. And I know the lobbying is strengthened by the research background. So they're not just in there saying, give us more. It's, we've got evidence behind what we do, give us more. And so I think that's, we need to support our professions. Our professions need to support us by doing this work for us. And our research, which we have been talking about through this conference, is an important ingredient in all that.
I've no problem in telling you the pay scales. I've just Googled what they are here. So we'll be open about this first of all. A physiotherapist, when they first start work in the NHS, just after they've qualified, will earn £22,128, and over their career they could get up into a leadership position where they get about £58,000. In private practice, I know successful private practices that will be earning 80, 90,000 pounds if they're really good and they've got a few clinics. One thing that it's taken me 72 hours to sort of digest is the amount of physiotherapy schools you have here. We have I think we've got 21 programs in the whole of the UK. Now, to get a new program, so if they wanted it to be 22 programs, that's a very hard thing to do, and it would be unlikely to happen. It has to be. We've got a strong leadership with the Chartered Society of Physiotherapy who govern things like this, and they're the gatekeepers to the number of programs, and the Department of Health dictates how many students per year can go on those programs. So it's a real market force thing. It's simply supply and demand, and it changes every year. So the number of students we can take, we're told every year how many that is, and there's a set number of programs, and it's based on the availability of work. So it's controlled at that level. So I'm just wondering what the sort of national leadership of the profession is like, and whether it's their jurisdiction to you know, make those decisions.
Gracias. Queda contestada la pregunta. Muchas gracias. Bueno, creo que el que se abran estos debates es necesario. Pues un minutito. Mire, hay una en la cuarta fila, sexta fila, y a lo último tenemos otra mano, y allí me lo está tapando el foco, ahí junto a la cabina de traducción. Perdón porque me da el foco en la cara. Creo que los debates estos son buenos. La primera planificación para la mesa era pues acabar a las 5, pero a mí me parece que merece la pena perder pues un rato más por este debate, porque es un debate que nos enriquece, con lo cual vamos a prorrogarlo pues otro poquito más, pues, dando la palabra aquí a esta compañera que la levantó con la mano. Sí.
Yeah. Yeah. He didn't. That's fine. Yeah. We're good.
Hola, buenas tardes. Bueno, voy a intentar retomar un poquito, que es bueno que hagamos esta reflexión interna respecto a la situación que tenemos en España, pero retomando un poco el tema del razonamiento clínico y retomando la pregunta que también, mejor que yo no la ha podido hacer mi compañero, al que todos hemos aplaudido, respecto a la situación de España, ¿no? Con el tema de las diferentes técnicas, que a veces nos centramos un poco en aprender muchas técnicas y nos centramos poco en intentar averiguar cuál es el origen del problema del paciente. No solamente el dolor, una disfunción, etcétera, ¿no? Entonces, sí que nos falta, hablo desde el ámbito privado, práctica privada, que al final pues, nos aislamos un poco en nuestro trabajo diario, ¿no? Que viene muy bien, y muchísimas gracias por haber venido, porque aportar un conocimiento internacional siempre nos enriquece. Entonces, muchísimas gracias a ustedes por haber venido. Entonces, bueno, retomando un poco el tema del razonamiento clínico, creo que nos falta un poco a la hora de tomar los datos iniciales respecto a la anamnesis, a la exploración, e intentar llegar a ese origen del problema. Creo que es extrapolable a mis compañeros. Tenemos una falta de informe clínico inicial y de progresión del tratamiento, que a veces nos centramos, pues bueno, esta técnica funciona, esta técnica no funciona, pensamos que tenemos que seguir formándonos en técnicas y quizá tenemos que hacer un poco de crítica, ¿no? de ese conocimiento general de otras ciencias y otras disciplinas, ¿no? que nos falta. Entonces, conozco en concreto la situación, quizá un poco de terceros, ¿no? La situación en Canadá, que creo que hacen un informe muy exhaustivo y no tratan pacientes sin hacer un informe concienzudo, ¿no? para evaluar todo tratamiento que se hace sobre el paciente. Si nos puede hacer alguna aportación, porque creo que es muy interesante, ¿no? para poder hacer un verdadero razonamiento clínico y que mejore, ¿no? en estos pacientes. Entonces, bueno, lo extrapolo a Reino Unido, Australia, si nos pueden aportar para que esa información no solamente de cara a la progresión de los pacientes, sino esa comunicación que posteriormente a la hora de derivar, porque hay muchos pacientes que tenemos que derivar a otros profesionales sanitarios, esto es como una segunda pregunta, tenemos que hablar ese mismo idioma que han estado ustedes mencionando en varias ocasiones, ¿no? Utilizamos diferente terminología, muchas veces nos vamos por la pseudociencia y aquí en España tengo la sensación de que concretamos poco a la hora de hablar con otros profesionales y tenemos que ser más concienzudos, ¿no? en expresar el mismo idioma para tener una buena intención y verdaderamente tomar el papel de un fisioterapeuta para que los médicos nos tengan en cuenta, para que los psicólogos nos tengan en cuenta y todo el colectivo y al final seamos un ente necesario para el paciente y tomamos ese papel de autonomía que nombrabas, José Antonio, pues, a la hora de valorar esa profesión, ¿no? Así que nada, si nos lo pueden aportar, pues muchas gracias.
¿Me permitís un momento como moderador para que haya más posibilidades para preguntas? Pues yo preferiría que sean preguntas, no declaraciones programáticas, con lo cual podemos dar pie mejor, pero te agradezco mucho, pero las preguntas quedaron claras para los dos, para ustedes.
So maybe I can just ask you a question for clarification about this idea of report, and that a report has to be done before you treat or assess the patient. Is that what you're asking? If that happens? I'll tell you about my experience. Oh, sorry. I'll tell you about my experience. Certainly, when we're asked to see a patient, as we're primary healthcare practitioners, so patients have a direct access to us, especially in the community. In the hospital, there are some policies within hospitals where the physician has to give a referral. But by and large, we can see the patient and do a full assessment without a referral outside of that. And so there's no real, I don't think there's a report that we have to do. There isn't a report we have to do before we then move on to interventions. And especially in private practice, it's direct access, so they can walk into a clinic and then we can assess and treat. So there isn't a stopgap there. There's not a step before we have to, that we have to complete before we see the patient. Other than if the patient wants it to be covered by insurance, they do have to have a referral in some cases. Is that what you're referring to?
No, me refería más a un informe posterior. Es decir, siempre que intervengamos a un paciente, tenemos que ser capaces de explicar lo que hemos hecho.
No. Not necessarily. Yeah, no. It's the same idea. So as primary healthcare practitioners, it doesn't matter if it's the initial assessment or subsequent visits, unless it's requested by an insurance company. And in some cases that you have to report back, but very few of them do now. We are able to proceed as we want to, unless there's some special case, and the insurance in that case would tell us that. Yeah.
Okay.
And I forget
Gracias.
the second part of it.
Si me, un minutito, señorita, me permite el micrófono por una razón. Está con nosotros el presidente de la Asociación de Fisioterapeutas que se marcha ya y me ha pedido la palabra precisamente para este debate. Permítanle que lo haga con mis disculpas para los dos o tres que había pendientes. Fernando, por favor.
Muchas gracias. Nada, yo simplemente pedir disculpas por entorpecer la dinámica de la mesa, pero sí que es cierto que quería estar en el acto de clausura, pero por motivo de vuelo, y ya que se va a demorar, pues tengo que ausentarme. Simplemente felicitar al Colegio de Madrid por esta iniciativa. Creo que nosotros los fisioterapeutas, y yo soy un fisioterapeuta que soy clínico también, pues hemos pasado de un modelo en el que teníamos ese prontuario de técnicas y que precisamente el razonamiento clínico nos permite ordenar la forma en la que actuamos y nos permite también actuar de forma más efectiva ante ese proceso tan complejo como es la toma de decisiones en el contexto clínico. Creo que esta es la línea, sinceramente. Veo que muchas de las alusiones de la sala tienen que ver con la pseudociencia. Yo creo que efectivamente tenemos una hoja de ruta que con iniciativas como esta está perfectamente trazada. Subámonos a esa línea, hagamos el camino que tenemos que hacer, todos unidos. Si yo lanzo una cuestión, y lo voy a hacer aprovechando y siendo un poco oportunista, y me tenéis que perdonar, si yo pregunto a cualquiera de los miembros que están en esta extraordinaria mesa redonda el papel que juegan sus asociaciones profesionales, sus asociaciones científicas, la APA, la de Canadá, la Charter, estaríamos hablando de un papel tremendamente relevante en el desarrollo de la profesión. Entonces nosotros en España también tenemos que mirarnos un poco el ombligo y ver que tenemos que estar todos unidos en torno a los organismos que nos representan, al colegio profesional, a las sociedades que tenemos, y crear también un cuerpo de profesionales que rememos todos en la misma dirección, y siempre, por supuesto, con una línea claramente marcada por la evidencia científica que existe en ese momento, la mejor evidencia científica disponible. Entonces, en ese sentido, pues animaros también a que generemos ese cuerpo y que la línea, que la ruta parece que está clara, y que también tengamos en cuenta, si nosotros, yo probablemente una de las preguntas que le lanzaría, y perdonad, es si a las personas que nos acompañan de fuera, si les llama algo la atención respecto a los asistentes. Es decir, nosotros tenemos que partir también de que somos una profesión muy joven. Es decir, antes Mark estaba contando que consiguieron hace 40 años la autonomía profesional, pero es que los 40 años de ellos ya tenían más de 60 años de historia en la profesión. Cuando en Australia consiguieron la autonomía profesional, ya tenían más de 60 años de historia en la profesión. Nosotros estamos como profesión en 1957, nos iniciamos como profesión. Entonces, entendamos el contexto y entendamos, yo no llevo tantos años en esto, pero entendamos que desde hace 10 años hasta hoy, hasta el punto en el que nos encontramos hoy, las cosas han cambiado muchísimo. Y probablemente todos hayáis visto hace 10 años como parece que solo existía una línea si querías trabajar bien al acabar de tu titulación, y que ahora tenemos multitud de formas de formarnos basados, por supuesto, en el mejor razonamiento clínico y basados, por supuesto, en la mejor forma de actuar ante la complejidad clínica de los procesos que tratamos en el día a día. Sin más, muchas gracias y gracias al Colegio de Madrid por la invitación, y espero que disfrutéis de esta jornada. Gracias.
Gracias.
Hola, buenas tardes. Es una pregunta súper concreta y muy terrenal, al lado de todo lo filosófico que acabamos de hablar. Es simplemente que estoy muy de acuerdo en la idea que se compartió ayer de que para hacer una buena historia clínica del paciente hace falta tiempo, hace falta tener al paciente y crear silencio delante de él para que el paciente se exprese libremente. Y os quería preguntar concretamente, en una primera cita en la que entrevistéis al paciente y le hacéis toda la historia, la anamnesis, etcétera, ¿qué tiempos concretos tenéis de consulta con cada paciente? Y si ese tiempo de primera consulta varía en segundas y terceras consultas. ¿Sí? Muchas gracias.
So the amount of time you have in an appointment, even in Australia, that varies. If you're in private practice, you can make those decisions. It'll affect your income, but you have that choice. And I would say, on average, the first appointment is usually going to be about 40 minutes. There'd be some places where it's only 30 minutes. I don't think it's ever less than 30, so 30 to 40 minutes. Very occasionally, I know of practitioners that always have an hour for their first appointment. So that's a big range, from 30 minutes to 60 minutes. And so let's say you have the average. You have 40 minutes. In that 40 minutes, you would probably spend 20 minutes on a patient interview, a subjective examination, and that that only leaves you 20 minutes to be selective on your physical examination. So part of your reasoning process through the subjective is not only what do I need to examine, what am I going to prioritize that's essential to look at the first day that still gives me time to provide an explanation collaboratively with my patient to implement some intervention, meaning it doesn't have to be a hands-on, it could be a home intervention, but I have to have some intervention, and I probably have to write that down as well. So I think there's a real key to being able to make those judgments about what's essential to assess. And even in the subjective, you wouldn't get through everything you want to, so you decide what you need to get. But what I really feel strongly about is you don't let your lack of time, like if you say, well, we only have 30 minutes, I couldn't possibly examine everything you suggest. I say, don't let that be your excuse. Just spread it over more appointments. So the second appointment, you reassess, but then you look at additional things, both subjective and physical that you didn't get done. And if it has to go to the third appointment, it does. So ultimately, you're still really thorough. I do a reasonable amount of second opinions, consultations, and I would say 95% of the time, it's not because I know more than the other physio. It's usually just because I'm more thorough. And I find things that they missed because they didn't look at them. So I feel really strongly being comprehensive in your assessment, spread over time, is important.
And I think it depends on your patient, right? So, you know, I'm big on contextual factors. So based on what your patient is telling you, maybe their goal is they need treatment now. That's what they want. And so I'm going to have to talk as I go, or that I have to shorten my subjective assessment. And to Mark's point, I think it's very tailored. So I'd love to have 20 minutes for every patient and just talk one-on-one and get the details about their subjective history. But the reality is that 20 minutes might be spread over 2 sessions, or that it might be 1 minute here, 1 minute here, 1 minute here, as I'm also doing some physical tests. So I don't know if I have a clear demarcation about time, but often in my practice, it's dictated by how much time I have with the appointment. And that I also want to make the point that my analysis continues. It starts from the very beginning. It continues after the patient leaves. Often as I'm charting, I'm also now analyzing and thinking about what I could do next time. So while the appointment is limited, I think the reasoning goes beyond just that time, and it has to be quite flexible within that time frame.
Bien, muchas gracias. Ahí por arriba, pues
sí.
otra pregunta.
Gracias. Yo de antemano pido disculpas porque más que una pregunta es una reflexión a colación de lo que se estaba comentando, bueno, de un poco la línea general de todas estas preguntas. También me hubiera gustado que el compañero que ha hecho la pregunta estuviera presente porque va un poco dirigido hacia él. Me ha parecido un poco demagógico la manera de expresar que el hecho de que haya un problema con los fisioterapeutas, la salida laboral que puedan tener, porque eso creo que es demagógico en sí. No puede ser nunca una excusa para la mala praxis. Es como si dijéramos todos ahora ¿qué hacemos aquí sentados con nuestras sillas de terciopelo viendo niños que morían de hambre en África, ¿no? Quiero decir que nunca puede haber una excusa para la mala praxis o para el campo o para abonar el campo de la pseudociencia. Y en cualquier caso, un poco para enlazarlo con algo que se estaba comentando, por si quieren hacer alguna réplica en la mesa. Creo que el pensamiento lateral del que hablaba Mark Jones antes es importante, pero hay que ponderarlo. Hay que saber dimensionar que de cada 100 ideas una suele ser la correcta y 99 tienen que desterrarse, y que normalmente el pensamiento estructurado es el que es importante conocer todo el mundo. Para el pensamiento lateral siempre hay camino, y yo diría que si algo sobra en fisioterapia precisamente es pensamiento lateral. Gracias.
Por arriba había otra pregunta, arriba.
Eso no va por mí, creo. Bueno, yo quería aprovechar que estamos en una mesa que habla un poco de autonomía y que estamos en un simposio que habla de razonamiento clínico, para preguntar a ponentes internacionales si ellos pueden hacer diagnóstico como tal. Nosotros los fisioterapeutas, hasta donde sé, y si no es así me corregís por favor, no estamos capacitados para hacer diagnóstico médico. Entonces, únicamente podemos hacer un diagnóstico de fisioterapia basado en funcionalidad, en FIF, creo. Entonces, esto creo que hace que de cara a otros profesionales se le reste importancia a lo que hacemos. No sé si eso ocurre también en otros países o no. Entonces, simplemente lanzar la pregunta para ver qué me contestáis. Muchas gracias.
Gracias. Creo, para que la sitúen, y si me lo permite el compañero, aquí en nuestro país hay reconocidos dos diagnósticos. Uno es el médico y otro es el fisioterápico, separados por una declaración, por una norma que los separa contra el parecer de los médicos que durante muchos años pretendieron negarnos pues esa capacidad diagnóstica.
I have an opinion on that. I think it probably is useful to have an idea of a physiotherapy diagnosis. If you asked me my diagnosis at the end of an examination, you would always get a paragraph. You would never get a single word. In other words, I wouldn't just categorize their health condition by a label, whether it was chronic pain or whether I named a particular pathology. So my diagnosis, which I think of as a physiotherapy diagnosis, is basically a little summary of my reasoning, which is, listen, here's the patient's main activity participation restrictions. It looks like it's this kind of pain type to me. These appears to be the main sources involved and the contributing factors that are responsible for the problem. It would be that sort of summary of my reasoning is my diagnosis. I wouldn't shy away from pathology because I don't think we have to avoid pathology. We just have to recognize the limitations of our clinical examination in confirming pathology. So I don't mind hypothesizing, and it appears to be consistent with a full thickness rotator cuff tear that I think is symptomatic, because I know you can have pathology that's not symptomatic. That's quite all right for me to include it, but it's just one part of my overall diagnosis that I will factor into my reasoning about management. So I don't avoid it, but it's a hypothesis.
Similar thoughts as well. It's, I mean, in the UK, physios are, by and large, do have the capabilities for a certain range of medical diagnoses as well. I don't know if it's that. I don't know if that makes us more respected or not. I don't think it is at all, but it is part of our role. So there's that side. But with regards to the physiotherapy diagnosis, again, I don't see why that isn't as important as a medical diagnosis. If you're framing it in the way, I mean, again, back to this idea that chronic musculoskeletal condition is the biggest problem in the world, blah, blah, blah. If you're making a diagnostic commentary on something that relates to that. So we do need to stop talking about things like the physiotherapy diagnosis is, you know, shift to the left, L3-4 stiffness, this range of movement, blah, 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 and all that bollocks. And talk in terms of meaningful things. And as Mark said, you know, capabilities and capacities for function related to meaningful health outcomes like return to work or risk of mortality or whatever like that, and talking a common, again, this common language thing that makes it meaningful. I don't in the UK I don't see a big problem with that, except if we start to talk in ancient physiotherapy vernacular, which we should have moved away from by now.
I think in Canada it's very similar. I would also add to their comments about this idea of diagnosis. So to what end are we trying to identify this diagnosis, whether it's a physiotherapy diagnosis or a medical diagnosis? To what end and to whom are we communicating this diagnosis to? That's something that we've been trying to do in Canada a lot, is to say, yes, you have arthritis, and that you might be saying that to the patient, or you might be saying that to the doctor that this patient has arthritis, But then to Mark's point is elaborating on that to establish meaning for that particular patient. So what does it mean? It may not actually be that dysfunctional for this patient, but they have this diagnosis, a medical problem, condition, but it's manifesting differently in this patient. And I think that paragraph is really important to the patient for sure. Patients always appreciate when you say, you have X, Y, and Z, and it's because of this, and you link things for them and tell them, this is why you're presenting this way in my clinic. So that diagnosis is very different. The way you communicate that is very different than if you say something to a doctor, and what they care about might be more that medical diagnosis. I think it's also important to push that a bit to say, it's relevant only to the extent that it's affecting this patient in this way, so that it's not just a diagnosis and full stop. So I think we have to, again, tailor our way of talking about diagnosis, and who are we talking, communicating that diagnosis to. That's something that we're really working on in Canada. I think up until, I want to say maybe 8 or 9 years ago, physiotherapists were not allowed to, in Ontario, in the province I'm in, we weren't allowed to say the word diagnosis to the patient. We weren't allowed to say, I think you have X, Y, and Z. But that's changed, and it took a while for that to change because of what I was telling you, that our meaning of diagnosis isn't just arthritis and full stop there. It's arthritis, for this patient, this is what it means. So I think when other people understood that, they understood diagnosis in a different way. So.
Bien, es una cuestión que guarda una íntima relación. El problema de nuestro diagnóstico, que en algunas áreas de la profesión pues no está bien pues establecido, pues a veces es porque hay un primer fallo en este primer periodo, que son los procedimientos de razonamiento, con lo cual precisamente el hecho de este simposio, que ya pues hay que irlo ya clausurando por una cuestión de disponibilidad pues horaria, aunque yo creo que nos apetece. Pues hay aquí gente de este grupo de Las Cañas que es muy activo por las redes. Pues digo, pues se andan por aquí, que hagan pues una quedada y pues se puede seguir pues el debate. Para la clausura le voy a pedir pues al presidente del Consejo General, señor Villafaina, que se incorpore pues a la mesa. Que creo que hay por aquí una silla. Bien, vamos ya pues rápidamente pues a la parte última, de clausura. Pues lo primero, pues en nombre de la Junta de Gobierno, gracias por vuestra participación, gracias por la actividad por las redes, que ha sido realmente muy pues elevada. Cuando esto se dijo que habría un premio, pues una beca de formación, y creo que este es el momento pues decirlo. El premio es para el tuitero, perdón, un minutito, Fisioterapia pues de Educación, que ha conseguido 277 tweets, pues no sé si está por aquí. Pues si no está, pues se queda. Y el siguiente es Patricia Moreno con 215. Bueno, pues están aquí. Vale, ahí está. Ya te comunicaremos como colegiada cómo se procede, que simplemente pues eliges un curso con la factura y se te reembolsa. Gracias por su trabajo. Y por lo primero, ya para ir pues acabando, agradecimientos para la Junta de Gobierno que han elaborado esto, para el comité científico que ha hecho una pues adecuada programación pues, de las mesas. Para unas personas les voy a pedir pues un aplauso que no les ven porque están en la parte última de la sala, que es nuestro gabinete de comunicación, que están acá a mi izquierda, que han pues, emitido varias notas de prensa y sin la cual pues este evento no tendría mucha repercusión. Es el grupo Servimedia, están por allá pues arriba, Beatriz, Sara, Patricia, nuestra tuitera. Un poquito para la parte pues, central, por detrás del cristal, en una parte está pues, Antonio, que es el que se ha encargado de que esto esté bien, las luces, la temperatura, por los micrófonos y junto a ello pues, el equipo de traducción. Gracias. Y ya pues, a la otra parte, nuestros hombres pues, de la imagen que han estado grabando pues, este evento, que lo podréis tener todo íntegro a partir de este próximo lunes en nuestro canal pues, de televisión Fisio TV. Gracias. Para los que nos visitan de pues, otra parte del mundo, vuelta para casa. Espero que se lleven de esta capital y de estos grupos profesionales mucho cariño, mucho respeto, pues admiración. Espero que vuelvan. Pues hay que decir, porque hay que ser crítico y la obligación de un responsable profesional es ser crítico, que se tuvo que suspender pues, el curso de Mark Jones por falta de participantes, pero hoy muchos colegiados me decían no se puede reprogramar pues el curso, pues se paga ahora, pues ahora mismo es complicado porque hay que efectuar pues un asiento bancario pues, por los ingresos y nuestra corporación pues, es un ente de derecho público donde no se puede ir con el fajo de billetes aquí para pagar, pero yo me comprometo y así lo digo aquí, en que vamos pues, a valorar en una próxima oportunidad, en muy lejana. Hay que pasar un periodo pues, obligatorio, que es que pues, se aprueben por los presupuestos de este próximo año, que esto se hará por la Asamblea el día 13, y en esos presupuestos hay pues, una parte de formación y que someteremos para criterio pues, de los colegiados, que son los dueños de los euros, pues la Junta de Gobierno pues simplemente pues los administra de forma transparente, pues leal, pero me comprometo para este próximo año, si es posible, que se pueda pues, efectuar pues este curso que, como bien pues no se ha podido hacer. Es un compromiso pues, de decano. Y pues, dicho esto, pues le paso la palabra pues, al presidente del Consejo para que... Pues,
buenas tardes y un saludo en nombre del Comité Ejecutivo del Consejo General que represento, y agradecerle al decano del Colegio de Madrid y al comité organizador pues la organización de este acto y haberme permitido estar también presente. Quiero dar, por tanto, la enhorabuena también a todos los ponentes, porque me parece que sus ponencias pues, han sido oportunas, han sido necesarias y de verdadera actualidad. ¿Por qué razón? Porque, como antes decía el presidente de AEF, pues ciertamente los colegios tenemos unas funciones concretas, que es la de ordenar el ejercicio profesional, pero muchas veces se refiere quizás a la situación académica, incluso laboral, o la situación asistencial en hospitales y demás, pero también hay que ordenar un poco lo que entendemos en nuestra presencia ante los pacientes, porque hemos pasado de ser meros ejecutores de prescripciones cerradas a ser clínicos, y esto es asumir una serie de responsabilidades. Ahora la mayor parte casi un 90% de los profesionales tienen profesión liberal y que por tanto pues trabajan fuera de las instituciones del Estado, que son las que aún nos crean algunos problemas que creo y estoy absolutamente convencido que cada vez tendremos menos problemas con ellos. Y por tanto, pues adquirimos esa responsabilidad y sin lugar a dudas, pues eso también es ordenar la profesión, enfrentarnos en la clínica ante nuestros pacientes, y para eso hay que saber lo que se hace con absoluta autonomía y con total responsabilidad. Y los temas que se han tocado aquí pues son precisamente para ordenar qué tenemos que hacer en la clínica diaria. Así que yo creo que ha sido un éxito, que ha estado muy bien orientada, y esto también es así. También anunciaros que se hablaba de, quizás no lo hemos tocado, qué pasa con las prescripciones. Me gustaría comentaros que los grados en España pues permiten prescribir sin problema ninguno y sin complejo, pero prescribir todo aquello que tiene relación con nuestra disciplina, con nuestra profesión. Y me hubiese gustado preguntarles si realmente ellos también pues prescriben productos ortopédicos, si prescriben ejercicios terapéuticos con toda normalidad, si prescriben hasta fármacos. Pero en fin, yo creo que el debate ha sido muy bueno, muy interesante, y quizás se podría haber tirado uno aquí 3 o 4 horas más, pero efectivamente esto hay un momento que hay que cortarlo, así que yo espero que hayáis aprendido mucho y que muchas gracias por vuestra presencia.
Gracias. Bueno, pues ya sin más un pequeño balance, creo que nos vamos con ideas que hay que desarrollar, hay pues ideas muy, digamos, pues etéreas que habrá que concretizar, pues hay otras más concretas que hay que traducir de este plano que hemos manejado aquí, científico, hay que pasarlo ahora a otro plano político, y pues ese paso es lento, es complicado, se merece siempre una labor, como antes ha dicho Mar, pues de reflexión, se merece una labor de, cuando des un paso, que lo des seguro, que nunca pises un terreno baldío, pues que te hundas y que te obligue a irte para atrás. Como antes he dicho, somos conscientes que es un momento, por suerte, de cambio. Es un momento que no hay duda que estas corrientes de pensamiento crítico que ahora mismo pues nos compartimos son buenas, son bienvenidas, siempre que sean constructivas, siempre que estén pues ausentes de la zafiedad y sobre todo siempre que se asienten sobre una pues herramienta para la Junta de Gobierno pues que presido, que es el debate. Pues hay campos para debatir, pues ahora mismo hay un marco regulador por la ecografía que se pues aprobará posiblemente la semana que viene y que permitirá que la Comunidad de Madrid sea la primera Comunidad de Madrid que regule la formación de pues ecografía, y no para fisioterapeutas, porque si pone para, pues es que no es para nosotros. Yo cuando veo lo de para, pues me da mucho miedo, sino en fisioterapia. Es la primera. Hay en marcha ya un borrador necesario políticamente de regulación de la formación de pues, ejercicio terapéutico, pues necesario. Y además pues aprovecho para, digamos, desdramatizar pues, una situación que nos ha podido preocupar. Unos señores se han reunido en una reunión y han dicho que quieren ser profesionales sanitarios. Pues nosotros, si queréis, podemos tomar como conclusión que queremos ser cirujanos. Pues no pasa nada, no va a pasar por aquí. ¿Por qué? Porque en Madrid ya se ha cerrado el reglamento que regulará pues, la ley, pues, las profesiones, pues, el deporte y con la participación del Consejo, y hemos conseguido eliminar, quitar todo riesgo de que profesionales no sanitarios puedan incurrir en este campo sanitario por una negociación puramente política, que es incluir en una línea 2 palabras: agentes físicos. con lo cual esto pues elimina el problema. Dicho esto, yo os pediría pues unión por la profesión. Hay problemas que se tienen pues que resolver desde el debate. Pues hace poco me decía un compañero que desapareció pues el Incitan, que es un fármaco, y no pasó nada. Pero durante 7 meses, 3 colectivos, uno pues económico y 2 profesionales, pues se pelearon en el Paseo del Prado. Nadie lo supo. Se marchó. Es evidente, y es nuestra responsabilidad, que hay que sacar de la profesión pues elementos nocivos. Claro que sí, pero hay que sacarlos de forma que no haya posibilidad para que se repliquen y, sobre todo, que la salida de estos elementos no ponga en peligro el tejido de la profesión. Si se toca una orden CIN, pues se toca para todo, no para quitar por lo que yo quiera yo, sino que hay una parte de defensa pública donde cualquier colectivo que ahora mismo no puede intuirse para nada en nuestra orden CIN podría pues aprovechar para pues eliminar competencias. Con lo cual, esta es una línea programática que yo creo que es compartida por el Consejo y que el Colegio de Madrid mantiene y va a mantener. La orden CIN no se toca. Por debajo se puede negociar todo lo que necesite en un marco académico, profesional y formativo. Y estos son los marcos en los que hay que debatir. Pues el académico con la academia, el profesional con los colegios y el formativo con los profesionales que reclaman a los proveedores de formación qué tipo de formación pues se necesita. Dicho esto, como ya nos veremos hasta el 13, que yo pues os recomiendo que por lo menos participéis por un acto de pues, homenaje a una compañera pues asesinada, pues a Lorena pues Enebral, que van a estar allí sus padres y que se le va pues a dedicar pues una placa conmemorativa y se pondrá pues el nombre pues a la biblioteca. Pues después de ese acto hay pues la asamblea donde se pues aprobarán por los presupuestos y pues os recuerdo que los presupuestos no son pues de la Junta de Gobierno, son vuestros y que lo que vosotros votéis es por lo que nosotros vamos a hacer. Gracias.